Hi, everyone. I'm Alan Skarbnik. I am the director of the CLL and lymphoma program in Advent Health Cancer Institute in North Carolina. And I'm here talking for the CLL Society. And we're going to talk today to Dr. Kerry Rogers, who will introduce herself, but she's at the Ohio State University in the CLL program there. We're going to talk about an abstract that Dr. Rogers presented at ASH in 2023 in December. Just for reference, is abstract number 3272, extended follow-up of a phase 2 study of early intervention with lenalidomide in patients with high-risk chronic lymphocytic leukemia. So Dr. Rogers, take it from here. Let us know who you are and what your study was about, and then we'll talk a little bit more about it.
Yeah, thank you so much. So I'm Kerry Rogers. I'm an associate professor in the Division of Hematology at The Ohio State University in Columbus, Ohio. And I think this is a really exciting follow-up study. So the original study is an NCI-CTEP-sponsored study that was designed to look at CLL patients who didn't need treatment yet, and if you could intervene early with lenalidomide, which is effective for CLL, but is not a commonly used treatment, to see if you could improve the immune system and improve vaccine responses. So the original design of the study was randomizing patients to receive either a pneumococcal vaccine and then receive lenalidomide after, or receive lenalidomide for 3 months and then the pneumococcal vaccine, and look at antibody responses. We did not find any difference between the two arms, the lenalidomide first or lenalidomide later, in terms of vaccine responses. However, the study has been open for a very long time, and we realized that we had given people with CLL lenalidomide for a very long time, and felt it was very important to look at the safety and the outcomes of people who took this as an early intervention. So just for some context, the study was started in the regulatory approval system here in 2010. So it's that long of a study. And the study enrolled adults with CLL. So they had to meet criteria for diagnosis of CLL, and they had to have a high-risk feature. And at that time, that was a FISH test showing deletion 17p, deletion 11q, complex karyotype, or IGHV unmutated status in the CLL. And then anyone that participated in the study could not meet the conventional IWCLL criteria for treatment. So they had to be people with CLL that had one of these higher risk features that didn't otherwise qualify for treatment and could enroll on this as an early intervention. And when people did receive lenalidomide, it was started at a dose of 2.5 milligrams daily, and it could be increased to 5 milligrams. The maximum tolerated dose in CLL is around 10 milligrams. And then the lymphoma dose, just for context, is like 25 milligrams. So this was a very low dose. And we just realized we'd had people taking this for so long. We actually took out the 3 months and normalized it to start date of lenalidomide for everybody for the analysis. But we had a median follow-up of 4.6 years and a median lenalidomide exposure of 3.7 years. So we thought we should probably look, at kind of how people did in this study.
All right, that's good. So just to add context here, the study happened before novel agents were approved for CLL, right? So before BTK inhibitors in particular, it ended in 2014, which is kind of when ibrutinib was approved for CLL.
Yeah, I mean, this study was enrolling at a time when ibrutinib was still in very early phase testing here, and certainly was not something that was being given to people who had not taken a treatment before. So yes, thank you. That's a very good point about this study.
Underlining that these are patients who did not require CLL specific treatment at that point. So there's a very interesting intervention here. But for clarity, no one in the study did not take lenalidomide, right? Everyone in the study was on the drug.
That is correct. Everyone in the study got lenalidomide. Some of them just originally had it start 3 months later to look at vaccine responses, but we kind of normalized that for this analysis to lenalidomide start, and 100% of people received lenalidomide.
All right. So just to give us some perspective here, I mean, these are patients with high-risk disease without need for treatment, and there are a number of algorithms that we can use to try and predict when patients may need to start some therapy for CLL. And the study showed quite a longer time than expected for patients to require treatment. So can you talk a little bit about that?
Yeah, so we looked at median progression-free survival. So that is patients that were, alive and without their leukemia progressing that started like after starting the treatment, and found that it was a median of 5.7 years from the time of enrolling to that's the median. So some people it was more, some people it was less. That actually is longer than you would think for the group of patients with the CLL that had this like high risk, one of these high risk features.
Mhm.
So I thought that was pretty encouraging. We also had people who took the lenalidomide and discontinued it for a variety of reasons, and then were able to stay in remission for some time. And just an easy way to think about that is the median lenalidomide exposure or number of years that people were taking it was 3.7, and the median progression-free survival is 5.7 years. So there was some time even after the drug was stopped. We did have two people that were still taking lenalidomide at the time of this analysis. So some people have been taking it for close to 10 years. We did look at safety, and I'll talk about that in a sec. I do think that it's important though to think about like which of these high risk features mattered the most, or were there features that mattered the most towards understanding how effective lenalidomide was as an early intervention, especially now, like you were pointing out with the new targeted agents, things like deletion 17p still do seem to matter quite a bit, but things like 11q aren't quite as important. And so we did do, and again, none of this is like a pre-specified analysis in the study. This is just an exploratory analysis we did because we realized that we wanted to capture the experience of people taking the drug this long or had participated in the study. So I don't want you to think that we planned this when we designed the study. That's not the case. But we did look at features associated with progression-free survival, trying to predict which of these features resulted in a shorter amount of time before the CLL progressed, and found that FISH positive for deletion 17p complex karyotype, or a higher rise stage, or IPI, which is a prognostic score, did predict a shorter time to needing treatment. So within our HERS features, it does look like there are a few differences. However, none of those actually were predictive of overall survival or how long people lived in general. And I do want to say that while the median progression-free survival, which is being alive without the leukemia coming back, was reached, the median overall survival was not reached. So at 8 years, an estimated 73.9% of people were still alive. And I think that's really good, especially because sometimes people die of reasons other than CLL. So you're probably not going to have 100% of people alive, and we only had 49 people in the study. So I think that this is really showing that you can get disease control with this, and that some of these features do matter even with lenalidomide.
That's great. I mean, this is, I agree, this is very encouraging. I mean, the question is like, can we bring Len back,
Yeah.
right? CLL, because it's not being used that much.
No, and I think we definitely can. And there were some concerns about lenalidomide from a safety perspective, particularly risk of second cancers was a big one. So we did do an analysis, just looking because we have a lot of follow-up now in the study of second cancers, and there really wasn't a very high rate, as you'd expect. And as most people might know, people with CLL develop a lot of skin cancers. So the most frequent type of second cancer people experience with skin cancers. But we only had two events of someone developing a second type of cancer that was kind of more serious. One was a lung cancer, and one was a squamous cell carcinoma that might have started as a skin cancer, but then spread to lymph nodes and was more aggressive. So
No
again, that's
hematological second malignancies?
no, I mean, there was a case of Richter's, but that kind of goes in the
Yeah,
CLL
just
lump.
CLL.
Yeah, there were not like any acute leukemias, no acute myeloid leukemias, no MDS for anyone during the experience we captured on the study.
Mhm.
And actually the rate of this looks high because of the skin cancers, but if you think about like the amount of time we had follow up and with this many people to, and the skin, not that skin cancers aren't serious, but just ones you remove and people move on with their lifespan aren't really the major thing that we worry about.
Of course, yeah, and then, for everyone's perspective, as you pointed out, about 20% of patients with CLL develop skin cancer. So I think it kind of stays around that number there. And it's surprising how lenalidomide can act differently in different diseases, right? And where it's placed. These are patients who didn't receive chemo, didn't receive anything beforehand. So the toxicity to the marrow is not necessarily there. It may be different than patients who get myeloma transplant and then get lenalidomide, which you have an injury to start with.
Well,
So
yeah, and sorry to, but this was studied after FCR too, so after chemotherapy as a maintenance as well. And I think you'd have the concern there, but really we didn't see that when people were taking this as like a first treatment. I think what you said is a very important point, is that they didn't have other marrow injury from things like chemotherapy.
that,
I think
that's
that's.
great. Yeah, no, that's an important point. So where do you see this going? I mean, do you
Hmm.
think there'll be a role? Because we know there has been, or there are studies going on for high-risk disease, early intervention, try to figure out if it's needed. So far, what the data we have with ibrutinib prolongs PFS, but hasn't had a difference in survival yet. So do you see a role? Do you see a future for this approach? What are your thoughts?
Yeah, that's very interesting because traditionally early intervention has not been something in CLL where we've seen it move the mark on survival. And all like the early intervention studies that were so this study is not big enough to look at early intervention and if it impacts how long people live. This is only 49 patients. The main statistical power of this was to look at those vaccine responses, like I was saying. And when you go back and look at early intervention chemotherapy studies, which were completed and powered for that, you don't see a survival difference between early intervention or not. And if you look at the curves carefully, you see chemotherapy probably hurt some people by taking it before they needed it. I think, what's being done now with studies to look at ibrutinib as an early intervention, and then there's a cooperative group study looking at venetoclax and obinutuzumab, which again is a shorter duration as an early intervention, are really going to be helpful towards understanding if earlier intervention is going to improve overall lifespan outcomes for people with CLL. And I look forward to kind of like seeing how that plays out. And I think it's important those studies be redone with targeted agents. But I'm not sure we're going to see a survival difference there, which is sort of what you'd want to see for an early intervention. Like people live longer if they're treated earlier, because we all know treatment has risks. I think for lenalidomide, in terms of doing like a large study compared to no intervention for early intervention is, potentially something we don't really necessarily want to pursue. But I do think that people staying on this low dose of the drug and in remission could be very helpful, particularly in a post treatment setting. So when you think about fixed duration treatments that are becoming more common again, so these are treatments you start and finish, including those with venetoclax and BTK inhibitors that are exciting, or venetoclax and obinutuzumab. I wonder if there'd be a role for maintenance with lenalidomide after that, especially for higher risk patients, where we know that more continuous treatment across different trials seems to be beneficial. And I certainly wouldn't be opposed to studying this as an early intervention overall, but I think the ones that we have going now as a CLL community are very interesting, and I kind of want to see how that plays out first. But I think as a post-therapy maintenance in a targeted agent, kind of like time-limited treatment study, that would be a very exciting thing to look at. And, most of the patients taking it, I get to see them in clinic, and that's not really expressed when you do an abstract. But a lot of patients don't feel very bothered by taking this in terms of side effects, especially at this low dose. For people that are remaining on it, seems to be more tolerable even than some people find the really highly effective targeted agents. So I wonder if that might be a role for it, but we're very open to other ideas about how to explore the use of lenalidomide, because I agree with you. I think it's been underutilized in CLL.
Yeah, absolutely. Well, thank you very much for this very thorough explanation, this very interesting study. We appreciate. I hope the CLL Society watchers here appreciate that as well. Dr. Kerry Rogers, always a pleasure talking to you, and we talk to each other soon. Thank you so much.